Hello, everybody. Today we're going to be discussing the slides entitled Neuro Part 1. Here are your objectives. The first thing we are going to talk about is spinal cord injury. So you can read the path of spinal cord injury, but essentially it is where there's some sort of trauma happens to the spinal cord and it is not able to communicate to parts of the body as it is designed to do. So we're talking about level of injury. There's 4 different levels of the spinal cord. The higher you go up, the more severity of risk the patient will have in permanent damage. When there is a spinal cord injury, or we believe there could be a spinal cord injury, there are 5 steps that you need to take in order to ensure that you don't increase the injury risk. The first step is immobilize the patient. This can be used with straps, with cervical collar around the neck. The second thing is we put oxygen on the patient. I don't care what their pulse ox is. You put oxygen on the patient and it reduces the afterload. Number 3, we're going to be doing a cardiac assessment. Just in case there is a cervical injury, we have to watch the heart and the lungs, and the cervical spine run the heart and the lungs. Number 4, we're typically going to be giving saline boluses, and we're going to get some IVs going on the patient. And lastly, number 5, you're going to have a CT done. And CT radiology will clear a CT bay for you when we have a patient with this level of injury. Mechanisms of injury. There are primary and there are secondary that we are going to talk about. There can be a complete injury versus an incomplete injury. A complete injury is where the section of the spinal cord has been severed and the patient will lose all function below the injury of where the spinal cord was severed. Incomplete injury is where there is some function and movement below the injury. There is a lot of treatment that we can do for incomplete injury. Sometimes the spinal cord, the vertebrae of the spinal cord is made of bone. So sometimes it can heal and the patient will either get all or the majority of their motor functions back. Sometimes if they do get most of their motor functions back, they can still have chronic numbness and tingling to certain areas where the spinal cord injury was affected. So again, the first thing we're going to do if there's any type of threat of spinal cord injury is immobilize the patient. Get a C-collar on. Second thing, breathing pattern, get oxygen on, airway. We are going to be doing Glasgow Coma scales. The lower the number, the worse the patient is. So if you have a patient where their Glasgow Coma scale is going down with every assessment, that is a call to the MD. Specifically, a T6 and above. T6 and above, that's talking about respiratory assessment, massive risk for a pulmonary embolism, very common for this patient to be vented and put on intubated and put on a vent and put in a medical induced coma. Very, very common. T6 also will be a risk for shock. So we're looking for hemorrhaging, internal bleeding. Where was the injury? We're going to be doing CT scans to see if there's any bleeding in the chest cavity, in the abdominal cavity, the colon, the kidneys, anywhere where there could be hemorrhaging going internal. And we're going to be watching for tissue perfusion. So we're going to be keeping an eye on the blood pressure, keeping an eye on the heart rate, because if that blood pressure starts to go down and that heart rate starts to go up, that is a sign of hemorrhage and poor tissue perfusion. That is an emergent phone call or rapid response or whatever you want to call. Okay? The majority of the time, CT scans are done. If the patient is stable after an injury and they're immobilized, you will have some some ER docs get a quick x-ray of the spine if we're waiting for CT, just to see if there's any bone fractures that we can see in the vertebrae. But a CT scan is going to check for any, a CT scan is going to be able to check for any bone fragments that may be in the spinal column, which is dangerous, and any blood in the spinal column, which is also dangerous, because there should not be any blood or bone in the actual spinal cord itself. And a CT scan is going to be able to see that. If it's inconclusive, the CT scan is not showing us anything, the patient's still having signs of issues, then the physician may order an MRI so they can see soft tissue damage. The reason we do urinalysis on spinal cord patients is we're looking for signs of shock. And the 3 signs of shock that we're looking for would be a heart rate going down, so they start to go bradycardic on you. Their urine output starts to go down, and then their limbs become weak and flaccid to the point where they can't lift them up. These are signs of shock in a neuro patient and need to be addressed immediately. So this gentleman has a halo ring screwed into the forehead, into the skull. And this is a fixation device when there is cervical damage in the spinal cord. So initially we'd put on a C-collar, but a halo device is going to make sure everything stays incredibly straight and aligned. And the patient will go home with this. So things we're looking for infection risk. Because if this gets infected, the infection is going into the brain. Okay? So the first thing, there is a wrench that we use that can loosen the halo device itself. I know this is going to be real low tech, but we just tape the wrench onto the vest he's wearing. You can see that it's like this hard epoxy white vest, and it's got fabric fur lining on the inside to the skin. We just tape that right to the vest. Super high tech, I know. You need to assess the halo sites for infection. So the halo that's going around the head, there are screws going into the skull. So you have to look for signs, symptoms of infection. If there's blood coming out, if there's green fluid coming out, if there's a lot of pain, if they have a throbbing headache. And lastly, we're going to be checking the chest and the back for skin breakdown, because even though that vest does have lining on it, there's a lot of weight on that vest. So we want to be watching for skin breakdown. So those are the 3 big things when it comes to assessing an individual that has a halo on. Some other treatments that we see with medications. A lot of these you already know, okay? Steroids, management of inflammation. So if there's a spinal cord injury, it may be inflamed. We give a lot of IV steroids, you get the inflammation down. You're going to be able to assess what the patient is actually going on. Do they have limited movement, or was it from the injury and the swelling, which would be a very actually good thing, okay? Dextron, this is a plasma expander. If they're hemorrhaging out, this is one of the medications that we give, okay? If they start to go into shock and they go bradycardic, atropine, remember it's only a Band-Aid, atropine's only a Band-Aid, but it will give you time to treat the shock. Dopamine and any type of pressors, that is going to help keep the blood pressure up, especially if you have a high thoracic or cervical injury and the blood pressure is dropping. We use muscle relaxers, especially if they're intubated. We use medications to treat bladder spasms, protonics for possible stress ulcers, pain management if needed. Some individuals don't need pain management. They can't feel anything yet. The patient's going to be on anaphylactic protocol, so they're going to be on heparin injections or Lovenox injections. And multiple reasons they could be on a stool softener, possibly pain medication, the immobilization. If the lower thoracic spine was affected, it can affect the movement of the bowels, so they might need to be on stool relaxers for that. And depending if their blood pressure goes high, they could need medications like nitroglycerin to relax that. They do need goals for bowel and bladder elimination. There are individuals that have indwelling catheters in because they have lost the ability to hold their urine. So that is very common for long-term treatment. And there's a lot of coping that goes along with losing the ability to walk or losing the ability to use a limb fully like you were able to before. One of the complications we see is orthostatic hypotension. So orthostatic hypotension happens when we change position with a patient, and it can be more severe if we do it rapidly. So we do this very, very slowly. This patient's going to have TED hose on because it increases the venous return. And as you know, every time you reposition to sit up or stand up, we check the blood pressure again and the heart rate just to see how we're doing. All right, complications, neuroshock. So we talked about this a little bit ago, just a little bit, okay? So the definition is immediate loss of total power. The sensation, everything relaxes below the level of the injury, and so everything basically gives out, okay? So when you have spinal shock, they can get hypotensive, they can get bradycardic. Their reflexes can be completely absent below the level of injury. They get flaccid paralysis below the level of injury. And typically spinal shock is temporary. It's a temporary unresponse to brain stimuli. So it can be treated. Neurologic shock, this is a sudden loss of the sympathetic nervous system. The symptoms are very, very similar. And it usually comes from vasodilation issues. So again, we can treat it, we just need to be catching it. So complications of neuroshock. One of the things we see is sudden bradycardia. So we're going to see hypotension. We're going to see everything goes hypo. If you know the list, hypotension, hypothermia, bradycardia, everything goes low. But the bradycardia tends to be very sudden. The treatments for this are pressors. We got to get everything back up. Very often you'll see the doc want to give an amp of atropine just to kind of start it out. Atropine is going to die off pretty fast. And then we could put the patient on dopamine, norepi, vasopressin, anything that's going to push the blood pressure back up. You push the blood pressure back up, everything will go into alignment. And obviously, this is an ICU patient. One of the big complications that we see is autonomic reflexia. In this, the complication is actually high blood pressure. High is high. It's super high. It's like stroke level. If we don't get it down, you're going to have a hemolytic stroke on your hands. We're going to talk about that next week, okay? So one of the first things you want to do with this patient is sit them straight up. 90 degrees. Sit them straight up, okay? Remember, this is spinal cord. Spinal cord, if they have a headache, sit them up immediately. If you have a patient with a head injury, you lay them down if they have a headache. Okay, those are the key differences. Spinal cord headache, sit them up. Brain trauma headache, lay them down. Okay. So the steps to assist with autonomic dyspraxia, I just said, number 1, sit them up. Number 2, get all of the SCDs, the TED hose, everything off and assess the injury, where the injury was actually taking place, and the skin below the injury. 3, give sitting up the patient 2-3 minutes and recheck the vital signs. Recheck if it has brought the blood pressure down at all. And then 4, depending on what the blood pressure is going to determine what type of antihypertensive and how much we're going to give. It's usually going to be low pressure, but depends how much we're going to give. And the last thing you're going to do is call the doc and tell them what happened and get further orders. So those are the 5 things in order that you're going to do. And this could be a constant thing. This could be a constant thing. You'll see patients fighting this if you're going to go into neuro ICU, and that there's just protocols with this. So those are the 5 steps that you take. Like we said, the first treatment, already went through the treatment. I wouldn't really worry about the causes as of right now. But hopefully, if you can prevent it from happening from assisting the bowel and bladder, it won't be an issue. But even when we assist the bowel and bladder, the autonomic reflex dysreflexia can still happen. Other complications you can see are pressure ulcers. So we're turning the patient using air mattresses, foam padding. They can develop osteoporosis, poor muscle mass, unable to use their lower limbs, so their chance of osteoporosis goes up exceedingly. We talked about the importance of watching respiratory, especially for thoracic and cervical, for blood clots. So question 1. A patient with spinal cord injury at the cervical 5 and 6 reports a sudden severe headache. The client is flush, the vital signs including a blood pressure of 190/100 and a heart rate of 52 beats per minute. What is the priority? So again, this is a spinal cord injury. So we would place the patient sitting up. Spinal cord injury, patient sitting up. Head injury, patient at 20 to 30 degrees. So those are some of the key differences. Question 2. The emergency room nurse is assessing a patient that fell off a roof and was transported by his wife to the hospital. list in order what the nurse should implement first. So if it is not already done, which hopefully it was by EMS, we have to immobilize their neck and spine. The second thing we do is we assess airway. The third thing we do is cardiac related. We're watching blood pressure and I'm watching heart rate. We can assess hypothermia, and sometimes that does involve saline placement. And the last thing we do is get the patient to CT.